republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Cordaro?
Here.
Andrews? Mr. Brady?
Here.
Mr. Holmes? Mr. Miller?
Here.
Mr. Meredith?
Here. Public comments, I don't see anybody online, so we'll move on. I have a motion to approve the minutes of the November 9, 2022 special meeting. Motion to approve. Second. Discussions? Favor? Aye. So moved. Abstain. Motion to approve the minutes of the November 15, 2022 regular meeting. Second. Second. Any discussion? Favor? Aye.
Hold on one sec. Mark says he can't hear anything.
Oh, okay.
Mark, can you hear us? No?
Can't hear you.
I got you. I got you.
Okay. Sorry.
Let's go to new business. I want to welcome Malia, Kara, joining us. And I spoke to right after our last meeting, we know a little more about, what operational metrics we do a little. What initiatives have you created since you started to cover this position? To get a better understanding moving forward with you.
Okay.
That with the floor to you.
Okay.
Everybody know Leah?
No, I haven't got to meet anybody but you.
So Leah is the last name is Bianca.
Correct.
And Kara Strauss is the board chair.
Oh, sorry, Raul Fernandez. Hi, nice to meet you guys.
Gary Paradise.
Tim Brady?
George Miller.
Mark Holmes is
Their box.
on my order. He's the sixth member of the board. And a couple of guests.
That's nice. So the board is on. Okay, okay, so I'll start with just what I started with, and then Kara and I can dive into kind of explaining how the financial world works within the Medicare and, healthcare world. So when I took over,
Can you give us a little of your background too?
oh, sure, yeah. So I got my BSN from St. Joseph College, graduating in 2009, and I worked in home care for 10 years. I also did 3 years of school nursing, a year in a nursing facility, and worked as an aide in the hospital while I was in nursing school. And I recently left one of the larger home care agencies where I was a field clinician, then an admission clinician just doing the new starts of care on patients. Then I moved on to the weekend nurse care coordinator role where I was course to nurses in the field and covered for the supervisor, did reviews of the orders that go out to the doctor, making sure everything was compliant and completed. And then when I left that role, my last role at my previous employer was in the quality department, working on incidents, complaints, quarterly chart reviews, quarterly audits, and just issues that they faced and looking into those issues and problems that they had with patients to come up with the cause and some things we can change to move forward and prevent those same things. And then I joined the Berlin VNA in the very last week of March. So I've been working hard there to get things in order. So I have been doing a lot of cleanup of the agency. There's a lot of things that, needed to be brought up to date. Barbara had done some things and really got us on that electronic medical record, using that more, getting us off paper. Doing a lot of things to just kind of bring us up to speed, and I just continued that. And the deeper I dove, the more issues I found. I did work with a consultant twice on some of the issues. So my time from March till now has been just getting what we need in place and kind of rebuilding the structure of the agency to have just a more structured workflow, and identifying what does everybody do, you know, what are their tasks. And so the latest thing I've been working on are a lot of the quality measures, looking at our policies and community outreach. And in January, I plan my networking and really getting good relationships with our referral sources. So I hope to see the census growing January and after. So January 1, we do have a new Medicare assessment coming out. So I spent the last 2 months educating myself and educating our staff on that, because that assessment is what decides our revenue for the Medicare patient. So it's a really important assessment. that
So are
determines what-
they rating you in different factors and you're paid based on that rating?
Yes, so in that assessment, we go in and depending on what the diagnoses are and some of the specific functional scores that we give, and then there's some questions that give us kind of a risk analysis to either increase or decrease that revenue that we get based on the answers of that assessment. So because we have a new assessment coming out in January, it's imperative that the staff is really comfortable and aware of what those changes are and how to ask the new questions and proceed with that assessment.
Do we have a current rating?
We have a what?
Do we have a current rating previous?
So, it's on an individual patient basis. It's very, you don't get a.
Chairman.
So let's see.
Hello?
To make sure you're asking a question.
Okay, so it's not like a skilled nursing facility where Medicaid is giving you a 5-star rating, a 4-star rating, blah, blah, blah. It's not like.
So there are star ratings, but
It's the payment model, so
yeah,
Oasis. So I'll just speak, I'm Kara Staus, I became the chair of the board in February of this year. After only being on the board for about 2 months. My background is 26 years in healthcare. I worked for Masonacare, one of the largest nursing homes, home care agencies in the state of Connecticut. So I was the director of risk management there, so involved in quality, patient safety, and operations, especially helping on the home care side. So, and I am actually in a new role. I work for an insurance company now, but still in healthcare risk management. So again, Aaliyah and I were kind of new coming in together, supporting each other, but what I've seen since I've been in is that there is a gap in knowledge and understanding how healthcare works in payment and reimbursement models. And so that's where, you know, Aaliyah, we talked in great detail on how we could provide information to this board to help you have a better understanding about how reimbursement works in healthcare in general, but specifically the home care. And what I think, I'll kind of tee up Aaliyah and then she can explain it because she's the expert. I know enough to get me in trouble, but the Oasis is what Medicare determines as a scoring per patient, that every patient has to have this completed at the start of care. And from the start of care, the nurse who's doing that initial assessment identifies scoring, which is what Aaliyah is talking about. And so in healthcare, what Medicare wants to see in scoring is improvement in the scoring. And the scoring could be, for example, ambulation. How
and this is scoring
Breathing,
between
yes.
the start of care and the discharge.
the discharge.
So they give us a rating based on how the patients.
So improvement in ambulation, improvement in, there's all different metrics that are tied into the care and the delivery that the nurse is doing. And so the educational component is not, it's not unusual to have, a huge education and teaching to nurses, because again, it's like a scoring. They have to understand the tools. Some of you might be familiar with the term PDGM, maybe not. That's called the payment-driven grouping model, which Medicare made a change 2 years ago. So at the same time of COVID pandemic, they made a change. And what that did was it changed the episode of the care from looking at 60-day episodes to then reducing it to 30-day increments, which would be increase in billing, more frequent evaluations based on the way Medicare changed it. And they changed it from being a therapy-driven metric to really looking at the clinical outcomes. So therapy is going to increase revenues. Traditionally, a therapy case where Medicare then made the change to change that grouping model. So there was a lot of learning curves that had to go into educating nurses during that time. And that kind of predates Aaliyah coming to the Berlin DNA, and now another change in the Medicare scoring. So you had 2 major changes in the Medicare rule for billing. So,
And then,
So is this correlation, how does that correlation in your rating relate to how they set your payments?
so I don't know if there's a correlation with
Okay,
the
so that's a
scoring,
separate, so it's,
but
here's how well you provide services.
yes.
That's what you're scoring is.
Yes, but also looking forward, there's gonna be even more of an attachment of revenue and quality.
big penalties associated with.
Yeah, so,
But it's basically still cost report that determines how much you're gonna get paid for each service.
I wouldn't say a
Cost report, that's more skilled nursing. The cost report is a skilled nursing model, not typically in home care. Home care is based on, again, it's the payer. I mean, I think Aaliyah, if you probably
Yeah,
look
but
at
it's
some
gonna-
of the, I think you had the different payers.
Yeah, so on the second page, I
Yeah.
have, we're not gonna go through it, but just kind of the information on PDGM that you can read at your leisure. So the reimbursement rates are here, and it doesn't have traditional Medicare because they don't have a set rate. Traditional Medicare uses the answers off that assessment to generate what they feel is an adequate reimbursement for that patient. So every patient is gonna have a different number. So with our non-traditional Medicare, with our private insurance, like we have here as town employees, Medicaid and CCCI and private pay, obviously we know what those rates are. So this shows you for each service, for each insurance carrier, what we get as reimbursement per visit. But if you look at the first page, I had reached out to Kevin to help me create some numbers that we could use to figure out the cost of visits. So you'll see for nursing, we came to the revisit is about $98 a visit, our cost. And when you compare that on some insurance carriers, we meet that, on some we get a couple dollars extra, and on some we don't make money, we lose. And then if you see the start of care and the recertification, those numbers are more because those types of visits take double and triple the time or more of a routine visit. So in our productivity for the nurses, they count as 2 for research, 3 visits as a start of care because they're extremely intense. So on most insurances, we start out on a negative and we're taking it back. And sometimes we do, sometimes we make more, sometimes we make less.
So you said you don't have Medicare in this chart. What percentage of everything you do is Medicare?
So out of 48 active patients, 12 are Medicare. But that fluctuates month to month. Because the referrals fluctuate, so. You may have a month where you have more, you may have a month where you have less.
What's the difference between Medicare and managed Medicare?
So traditional Medicare is just that traditional Medicare A and B. You haven't signed up for anything extra. The managed Medicare are the United Healthcare Medicare, the Anthem Medicare, the Aetna Medicare.
Medicare Advantage,
Yeah, they're a different selected plan that are Medicare, but through a different carrier. And those do not pay the same as
So then we're talking about 29 out of 48.
most people have managed Medicare.
do they
Because they
follow the
offer-
same model as Medicare or more along the lines of insurance carriers? Because they're managed by the insurance carrier.
But we still have all the requirements of Medicare.
So they're paying based on that Medicare schedule.
They pay based on their own carrier payment, but we're required to do all the work in the same aspects as a traditional.
Are they
The same.
somewhat similar in their reimbursement as the
No.
ones? No, they're less.
Well, no, these include the, I'm sorry, these numbers include the managed Medicare. They are, United Healthcare managed
Okay,
Medicare.
all right, thank you.
Sorry. Anything else on those? It's a lot. I don't know that we'll like get through it all in one.
We appreciate your.
Oh, that's okay. I'm happy to be here.
Who coordinates with the insurance? Insurance says, all right, visits, they're fine. Who communicates with insurance saying, no, it's not fine, this patient's not okay.
So certain patients require authorization for visits, not all patients. So it's based on the judgment of the clinician in the field, to determine whether we need it or not. If we have a skill and can prove skill of why they need it, we can ask for more. Marlo does our billing and coding, and she would reach out if we needed authorization. We always get pre-op. So we always have authorization for the visits that we're gonna do. And then we know when that is gonna be coming to an end, and we'll evaluate and get more off prior to. So if the insurance company were to just say, no, we're not gonna do anymore, or you billed all the visits we'll give you, then we would have to, I guess, discharge it or offer private pay or that. I don't think we've encountered.
So if that happens, if it goes to private pay.
That's a big hypothetical. That really has.
They hypothetical,
Yeah.
yes, but. Still,
Just as a baseline, could I ask you one other question with regard to your disciplines here?
Yep.
As far as the in-house staff,
Mhm.
what do we have?
We
Like how
have,
many,
yeah,
like
we
for
have-
this part of the business?
we have 3 full-time registered nurses, 3 full-time home health aides, and the rest of our staff are all per diem.
It's the rest of it.
So
So
we
we don't
have
have
three-
OT, PT.
We have 3 per diem PTs. We have 1 per diem OT. A second is coming on board. A social work that is in the process of the hiring steps. And then we also have 1 speech therapist who's also per diem.
So the social worker you're hiring as a town employee or that's per diem?
They're per diem.
They're per diem.
Yeah. And then we have 3 office staff who are.
Um,
One of the things you mentioned in your opening comments was that in January, you're gonna be meeting with referral sources.
Mhm.
You've been here since March. What, in doing that, what are you gonna do differently than your predecessor?
Well, I don't know how much Barbara got out and was able to do that. I know her time was kind of short and she was very busy.
Because every director who's come in here talking to us has always talked about expanding referral sources, everyone.
So I think what we need to do is really focus on a few that we can get a solid relationship with. I think that a good place to go and to start is UConn. They do not have their own home health. And we've heard that they're a little frustrated with some of the other agencies. We do get a decent amount of referrals from them already, so I think they'd be a great hospital to work with. And nursing facilities, Bel Air, I have an appointment with. And we get quite a few referrals from them, and I'm gonna take a look and find out what our other biggest sources of referrals are for nursing facilities. I think there's been kind of an idea to try to connect with assisted livings and doctors, but not all those people need home care. But patients discharging from nursing facilities, patients discharging from hospitals, there's a higher percentage of those people that are gonna need home care. And if we can have an agreement that maybe we're the priority home care for Berlin patients that they have, that they ask about using us first. So I think it's just about making those good relationships, and I know previous administration, not Barbara, but before her, did not have really their referral sources. Sometimes rude to them is something that I've heard staff. And just kind of burnt bridges, so just letting them know that there's somebody new. And just building that trusting relationship with them, I think we can definitely have more referrals coming from selected sources. I don't think it's about getting relationships with 20 places, yeah, that's great, but if you have 3 or 4 that are really consistent and you know the people, you know the information you're gonna get is correct, and you have kind of a priority relationship with them, I think that's a better.
So my dealings, I dealt with a little bit, with somebody that we're kind of under our wing, taking care of in assisted living. Currently in a skilled nursing facility, has had home care, so it seems like with regard anyways to a skilled nursing facility and or assisted living, their needs are more centered around PT and OT. Whereas like PT are a real lot. So using per diem, is that advantageous to us? Do we make money off of those deals?
It's less expensive for us to have them,
Is it?
sure, yeah, because we don't have to pay them for the benefits.
Like your reimbursement rates allow us to make some. Allow you to make some money off of that.
Most of
It's one
the
thing to be in a
therapy
business and you don't make
reimbursements-
any money, it's like,
Yeah,
and it's then you still got all the overheads and, all this. Operational staff and whatever, that's why I'm asking.
the finances in healthcare, I think, have gotten really tight, and there's even doctors who are just retiring because it's just not financially what it used to be, and
My other question along that, individual that I care for, she had like 2 to 3 weeks of in-home care. It was nursing, PT, OT, home health aid. The way that it was dealing with though, it was like there was an RN. The RN wasn't in the picture all the time. The RN had to make a presence like once every 3 or 4 weeks, and other than that, they used LPNs.
so that's an experience with a larger agency who can't
That
keep up
was
with.
a Trinity, was the agency. They're not huge, but
So there's been some trends in the home care space to include LPNs,
okay.
which is okay, but they are very limited in what they cannot do the same things. They can't do a recertification, they can't do a start of care,
They
they,
can't assess the patient ultimately, they're not a nurse.
So I mean, that's what
They
the
need to
very
be
first, the
supervised.
very first dealing with this person was an RN had to come in. Then there was probably 2 sessions with an LPN, and the RN had to come back in, probably the recertification or whatever. you
So
call it.
that example that
understood
you're
that.
giving is what makes this agency completely different than your traditional larger. I can say that coming from the agency I came from, same thing, it was a different nurse and it was a different person each time, so that patient was retelling their story each time, and
Well,
that
I-
nurse had to be educated, and if not the patient, the family that's there or caregiver. So it is a different, when you get into bigger models, they do backfill with the less expensive
I
LPN.
can attest to what you're saying, that it was not ideal.
Mhm.
The person had dementia and it was a nightmare.
Absolutely.
Or a
yeah,
dementia patient, it was a nightmare. Who are you? What are you
Right.
doing here?
Exactly.
No, I don't wanna talk to you.
Right, I don't want to help you, right?
It was a nightmare.
So a lot about the Berlin DNA is the difference in experience. I know that services, you can get that from a plethora of agencies, but the experience you get with us versus with other agencies is unique. Because of that, you're gonna see the same staff. We don't have a lot of staff. You're not gonna see somebody different every time. You're gonna see your case manager. I can tell you that our communication in this agency is far beyond my previous employer. It's just excellent. The continuity of care is great. And I think that that's why the people voted to keep us, you know, that they want to keep the good services that they've been getting and that they can trust. We went a little off topic there.
You want to talk about the
That was
comparisons?
Right? So,
What's up?
that was both. Like, we are trying to help you guys,
Oh, I know.
so no one's trying to cut. But again, I guess we're doing intention, for that to turn me down. But, I think all new this is a business, right? We're trying to make it work,
Okay,
not just for you guys. We appreciate the trying.
I didn't mean that as a negative. I just meant
It
that,
came across a little bit, but we're okay.
okay,
We're
Yeah,
trying
the
to,
vote is over, so what do you- it is what it is.
that is what it is.
well, I just meant that I feel that there's a responsibility to maintain the quality and type of services that the public has been provided.
I agree with you 100%.
That's all that I meant
I
to
agree with
say.
you
I don't
100%.
mean that it came
But
out.
it's just not
different.
those services. It's town-wide service. Like, we just bought a fire truck, it's 2-year planning. And you guys had that loss in 1 year. So we're all trying to work this out and trying to figure it out. But no one is here, no one's trying to destroy the community, trying to save the community. That was from the start.
Right, and I think that the purpose of Aaliyah and myself coming to this is, again, I've never come to a Board of Finance meeting. I've never been on the board. No one ever came to the VNA. And so I think what we've seen here just in the 20 minutes that we've been talking is there's a huge knowledge deficit, which rightfully so. I don't know the ins and outs of what Kevin does. I wouldn't want to know it. I don't want to be in that job. But I think that what we can appreciate and what we can agree on is that it's important for those that are in this room doing what you're doing from a finance position. Obviously, businesses are in the business to make money, and operational losses is never good in any company that you go in. But I think that there is a uniqueness to healthcare, and especially a town having a home care, an owned home care agency. And I think having an understanding a little bit more about the inner workings and how it is a little bit different, because the reimbursement rates are outside of the control. It's not like you can establish a rate. We're going to charge a fee for a service. So, you know, you're gonna go cut down a tree, it's gonna cost you a fee, and you can price that out and do an RFP. But with healthcare delivery, you're at the mercy essentially of your referrals and the insurance that they're coming with. And so I think that that's really what the goal was, is to kind of explain that a little bit more, but then also talk about the numbers from a census standpoint, because I did listen to, I think, one of your meetings, it must have been right before, it must have been October, that there was some questions about understanding the number of Berlin residents that are on service versus out of town. And there was, again, I couldn't really hear the recording well, but there was a comment about the continuation. So you wanted to know the number of new residents that were on each month, not carryover, if I understood that dialogue correctly. So Aaliyah and I were kind of talking how she could explain.
I think the dialogue,
That-
sorry for the dialogue in that conversation, I think I initiated the conversation.
Okay.
It's the fact that all the users, all the locations are with Berlin DNA. Is being supported with Berlin tax money. How many of those patients are out of town? Like, I don't think the Berlin should be in the business of subsidizing other towns' patients. And I think using tax money. Are we in agreement on that, at least?
So I think where the theory came from, I think with the VNA was that if you had the staff and you had the capacity and you had referrals, if you're already paying the staff their salary and wages, the minimal expense of mileage would be what you were incurring if you were going outside the district of Berlin. So that would be, there's no difference of a town, if someone lives in New Britain and is getting the services of Berlin VNA agency staff, because you're getting the reimbursement from the insurance company. And it's not based on the tax dollars, it's the salary and wage that the agency is already paying. So really the expense is mileage to drive outside the scope,
So
so.
there's two arguments to that.
Yeah,
You're
that's
looking at a very small incremental cost.
Mhm.
When you're dealing with per diem employees, that's not the case whatsoever. Because if you send a per diem person to Newington, that's not part of the town dollars, right? That's not in the payroll per se, or that's dollars you would not have
Sure.
to spend. They're not on the bench, town employees getting paid anyways. Then you gotta look at the situation. Now, I'm not advocating this at all. We're just trying to do our due diligence in terms of what we feel we owe to the town to make sure is that, you know, it's like, if you don't have enough work for the people that you have, then over time you could do some attrition and get it down to the number of people you need, and that would lower the costs to the town of Berlin. So you can't look at that little incremental and say, oh, it's only the time. it's
No, but
only
I
the
think it would
gap
be helpful
going
to
out
know the
there.
number.
It might be for a small period of
Sure.
time, but if you consistently had a third of your work out there and you got rid of a third of your workforce because you don't really need that bench to service Berlin, that would in turn lower the cost of the town of Berlin. The other issue is, one of the questions that I've asked repeatedly, I don't necessarily have a problem with the VNA doing that, but my fundamental question is for an outside person, what does it cost to generate $1 worth of revenue? Okay, that's the question that needs to be answered. If it costs $1.10, we shouldn't be doing it. If it costs 95 cents, go for it. Because that helps us.
But you're not knowing the Medicare reimbursement rate.
That makes it
Makes-
difficult.
Well,
And this is, I noticed on your goals here is to increase the census. I know you guys are new to this, but none of us here are. And we've gone down this road more than once already. And increasing the census has done nothing but increase the loss. So we're looking at it numbers wise, and you're saying we need more people. And our experience is every time the VNA takes on more people, they lose more money. So you're expanding the loss by expanding the scope of the VNA. And now we're
That's not-
expanded to out of town. And we're seeing the same amount of loss that we did pre-COVID. So I don't see
but
how. this is-
pre-COVID, there was a different payment model. So in the time of COVID, different payment model, different assessment. COVID, where agencies nationwide were losing money.
Well, we can disregard COVID because I understand there was problems there. Because that was, they were back to $990,000, I think, in 2020 was the loss.
But when you stop or lessen the referrals, you're gonna lessen the revenue. And administration in the past, from what I've heard from staff and what they've told me, wasn't doing it right. They were keeping people on, overutilizing tons of visits, just keeping people on for a long time to have a good census, which the census number is almost irrelevant. It's based on payers and the cost.
Is that a supervision problem or a nursing problem?
That was a supervision problem. They were being instructed to do things that were not right. And I don't mean like illegal, but just not the right way to run the agency with the changes in the payment models.
And you have to understand, those are the people that have been coming to us for the last 5 years.
I know, and I am.
Telling us that they're changing in their approaches. And if they think we're hard on you,
And that's
we
okay.
are,
That's
because
okay. It will
we're
change down the
hearing
line.
we're hearing it, we're not seeing anything different.
And I can understand that, and I put that as a barrier. There is I use the word mistrust, maybe that's not accurate, but maybe a hesitancy, maybe just for the time. I'm
Empty
on your
promises,
side,
No
and I
delivery.
don't blame you. And what I heard that the staff went through in personnel issues and all sorts of things, it was a nightmare. And I can't believe that some of the people stayed through what they dealt with,
Well,
but
I think though what we're looking for too is, say you're trying to increase your census. Look at your modeling to say, if you're gonna increase 20 people, what does that mean to the cost structure? So that you have some understanding that it doesn't take us the other way, as opposed to
Yeah.
maybe help you, get to, reduce your overall cost or loss, you know what I'm saying? So that's what we're looking for. Now, I mean, like you said, we're repeating the same thing. We've heard the same thing for the last 5 years.
that
So we
must
want
be
to,
incredibly frustrating.
when we hear new ideas, now we want to see some data that helps us, get us over that, that situation.
So I'm just thinking again, thinking out loud. So I'm hearing a lot on the per diem. So per diem kind of utilization and that cost modeling, if we can look at that maybe on how.
Well, I can tell you already, our 3 full-time nurses do an alternating weekend rotation, which is paid in overtime. So I had a per diem nurse and she's helping us, and that's reduced the overtime. And it's much less expensive to give her the visit than to pay overtime, so we've been doing that. Unfortunately, I learned that she was offered a Baylor position that I can't offer her. And probably won't be available for weekends anymore, so we'll have to find somebody new. But yeah, the per diem is great to reduce the overtime. And just to comment, there really aren't people sitting on the bench
I
with nothing
didn't-
to do. Well,
Well, I mean, if you didn't, what if you
There's-
didn't have any of the outside work,
if we didn't have any of the outside
out
town
of
work,
town work?
I mean, last month we took 5
Just
new
look at
admins who
Look at a
were out
bigger
of
picture,
town.
a bigger timeline. In the
I mean,
course of a year, if you didn't have any of the outside work, but you need the staff you have.
As we
It
work
just really
forward with
reduces your
1/3
ability to grow too, so I'm
But
not sure.
growing,
that's the
if you're gonna
right
lose
thing
more
to do.
money, is not what we want to do.
But growing and not losing money is the goal.
Yeah,
Agreed. Yes.
No, growing
You
and
know.
losing less,
yes.
Yeah,
not staying the same.
yes,
I mean, from my perspective, we lose too much money, all right? I am an advocate for saying, I want you guys to lose less.
Yeah.
Okay, not stay the same.
that's everybody's goal. We're on
Okay.
the same page there.
And I think to that point, I mean, I've been working with municipalities for a long time. There used to be a lot of VNAs run by towns, okay? Now there's 2. 2 others, right? Orange and
Westbrook.
3 others. Okay, what is it, Westport? Or
Westbrook.
Westbrook? Now Westbrook pretty much,
They are also Westbrook.
Westbrook does Westbrook, and they pretty much run a balanced budget. Have you looked at that model at all?
In Westbrook?
Yeah.
So I guess we could look at the model, but I'm not sure that it would be really appropriate here. We have higher population of citizens, but it's a bigger town. And I worry about relying almost solely on per diem staff, because they can decide at any moment that they're done and they don't want to work with you anymore. And when you start getting home health aides that are per diem, you kind of start running into issues of reliability and transportation and other things. So I have not been that interested in the Westbrook model. I had information from Arosha, I had information from Barbara, and I'm just not confident that the same thing will work here in the same.
So the information you gave us here, is there anything else you'd like to highlight for us?
I guess just some trends, so this top chart here just kind of shows you comparing 2021 to 2022, the total monthly patients, how many admissions, how many research, how many discharges, so just kind of quick comparing there. we can see that we had some good months, then obviously there's kind of a dip. When there was the transition with Barbara coming in and kind of another year of COVID. But as you can see, kind of trending, more admissions, less research, meaning we're keeping patients on for less time, we're being more productive at each visit and therefore not needing to continue care as long, and more discharges. So we're, again, just showing that we're not holding on to patients as long as we were previously, which is important for that new model. I guess the other portion is just that I've been very aware of where the referrals, when we get referrals, looking at, you know, where do they live? And just being cautious about how many we take from out of town. And we definitely reduced that. It was more like 40% previously than the last time that I looked at it was like 14%. So we've reduced the out of town, but I'm not sure that eliminating that is the right way to go either.
Jen, I don't think anybody's saying eliminate it.
Yeah.
All I want you to understand, I want you, this is your business, understand your key performance indicators. One of them is cost of service versus revenue coming in, okay? Just make sure that that dollar of revenue coming in doesn't cost you $1.10, that's all, you know?
Yeah.
It's just.
Because that's not palatable for people in the town, believe me, that's not palatable for us. That's not what we see as the role. You know, if I don't even have as much of a problem if it's all Berlin residents that you're helping. This is our town and you're giving a better quality of service. If it costs you $1.10 for a buck, I'm more fine with that than having it cost $1.10 for an outside person. And that, you know, if you get your census up, if you can concentrate to a degree, if you're all Berlin again, that would be great, because that's what the VNA's roots are, you know, 1926, whenever, you know, an agrarian town, not all these medical facilities around, that was their role, that was where they came into their prowess, you know. That's what people remember.
Yeah.
All those old farmers that said, yeah, let's keep going. Believe me.
Well, and kind of in that spirit, I've taken an initiative to have a bigger community component. And I want to provide more services to the town, not just home care patients, not just the kids in the schools with the school nurses, but having actual health related educational sessions or where the service is provided. Like at the library, we have the ice cream event, which promotes us, but it's a fun way to get out there and talk with the community. And we provided free vision screenings with Lions Club to pre-K and, you know, early childhood age children. We had another event with the police department on bike safety and wearing your helmet. We've been to the senior center at their health fair. We were in another health fair at a gym in town. It's in fitness. So we are really trying to get out there and provide value to all the citizens, and so that we can kind of reach everybody who's, you know, paying into the taxes and helping us out. We want to give back and provide an opportunity to serve different demographics of the town.
So it was interesting. I had a conversation with a friend of mine who lives in town. She's probably in her mid to late 80s or whatever. She had an issue, she fell, she hurt herself, and she used you guys, okay? And she was very, very pleased with it. But my conversation, the enlightening part was like, I didn't realize I could call the Berlin VNA. Nobody offered that as an alternative when she came out of Harvard Hospital, out of Yale Hospital, or out of that's, you know, so I don't know how you come
That
up with
was-
that.
That was a conversation at the meeting, that's illegal for healthcare systems to not provide options to patients upon discharge. So that is what you see in the big, you know,
I've
they,
never seen it.
yeah, so they refer to themselves and they don't give a patient an option. So if you don't go in as the patient saying, upon discharge, I want Berlin VNA, you're in there in crisis, right? How many planned surgeries, there are some, so they're gonna come to you, oh, here's our home care, here's the number. And that's what they do, and it is not, it's illegal, they cannot do that. And so that's where Aaliyah's gotta make those relationships with those non-hospital home care driven agencies like Hartford Healthcare, I'm gonna say the names. You've got Trinity, and Yale, St. Francis Trinity, it's the same thing. So you've got going to UConn is a great, opportunity to obtain referrals and get that relationship,
I think,
established.
just an outreach to the seniors in this town to let them know that, hey, if you want your hometown people caring for you, if you come into this situation, ask for Berlin VNA.
We've talked about the marketing.
We have plans.
Yeah.
So we currently do a weekly blood pressure clinic at the Berlin Senior Center. And we are going to reach out and try to initiate all of the senior housing. I can't remember all the names of the top of my head now. I have them, yeah. But they all have community rooms that haven't really been used since COVID because people never really came back to using them. But if we could do an hour education session or a blood pressure clinic there and just offer that, service to people. in the
I would
community.
recommend an ad on the citizen districts. And just run the Berlin Pleasant office.
We just have to look at that because marketing budget is not very great.
Facebook's pretty cheap.
But-
Facebook's very, very cheap. Is there anything that prohibits them from having a brief thing inserted into the tax bills?
Or pamphlet or something. Go, I'm gonna get checked.
Go along with the water.
Even a link to the website, just a simple, hey, remember the VNA, we're here to service you.
It's kind of about like a did you know Berlin has, like kind of like a USA Today style, colorful, easy infographic.
You might wanna ask-
Getting that out to not so much the seniors, but also their children as well, because they're the ones that are navigating the care. So it's getting that that baby boomer generation, getting their children. I'm a lifer in Berlin and my mother went to Masonic Care's home care. So here's a classic example because I work there. But now my dad may need services, so I'm saying, Aaliyah, bring them on. So
just look
Yeah,
at
and I
those
think it's just spreading the
non-organized,
word, yeah.
Opportunities, have a conversation with a Roche, maybe, something with the schools.
We've talked about-
Non-service, it's not a.
we talked about Uncle D's getting on the menu. Their menu has, or like their placemats have marketing opportunities where we could be inexpensive, kind of big wins. Social media is huge. But again, it's like another job for Marlo to take on, is how you get that footprint and then you have people like and share it. So, yeah. But we have definitely, brainstormed, and there was a lot that was done between the Memorial Day parade. There was a booth at the Berlin Fair for the VNA. So there was a lot of outreach that has happened in a very short period of time from when Aaliyah took over. We were the farmer's market when it was in existence. So again, trying to be creative, and we've taken up.
That's part, we've always asked for a more solid marketing approach. We've never seen anything, I'm saying,
Yeah.
whether it's even a pamphlet or something you guys hand out or whatever.
Yeah, we've got the pamphlets, we've got our little kind of mailer cards, we have all sorts of stuff, we have marketing items that we give out. I mean, at the farmer's market, we had these nice tote bags, we gave those out so people could put their stuff in that. And, yep, the Berlin Fair and the water bottles. So we're really making an effort to be more visible to the town people, to let them know, like, we're here, we're ready for you, we want to hear for you. And we didn't get into this, but this is another spreadsheet. I didn't hand that out to everybody. So this is like a tracking sheet for me, and I'm doing it month over month, and I guess I can just leave this with you if you want. It doesn't have a key because it was in black and white, so just tell what's what, but
Send it to Kevin.
Yeah.
okay,
Send it
I'll
within
do
a
that.
that's a
Yeah.
good idea.
Okay, because then you can see, so when the patients are discharged, I'm going back and looking at our cost of care and what our reimbursement was and what was the outcome. unfortunately, this is all manual work, so it's very time consuming to go back in, so I don't have a lot of completed months to get back to you, but I'm working on that little by little every day. But it just kind of shows you, so this one was from October, and from what we have discharged so far, we had losses on some patients totaling $1,101, and on the other side, we had a gain of $95.99. So good numbers there, over, but this is gonna help us to look at trends. Is there something with a certain primary diagnosis? Is there something with, you know, certain days of service, how long they're on service? And that's gonna also let me know our out of towners, you know, how are we doing month over month? Are we gaining or losing on our out of town patients? So once we have more completed months, we can really get some month over month trends and some data to drive where we go in the future. But
And we're looking for some kind of progress. All this bull about trying to close the VNA down was all fabricated. We are just looking for progress.
Yeah.
And we haven't seen not one penny's progress in all the time this has been going on. So if you can show us any kind of positive progress, that's a help,
That's what it comes down to.
you know, really, that's all it comes down to.
I just am, I guess, worried about this upcoming budget because I don't have a lot to show you right now. I have my word, but I know that that is not so meaningful at this moment in time. Hopefully in the future, it means a lot. I'm hoping to show you that it's solid when I tell you. So I just don't know what the plans are for this upcoming budget, and if I am going to have, you know, the remainder of this year and maybe next year to show that progress and move forward. And I'm really focusing on the financial aspects. I mean, I bugged Kevin, I don't know how many times, but educating myself on every line and what's in that line, what can we cut? And going over that budget for the new year, I think we cut something around like 15, maybe more $1,000 that I was able to cut, but we're kind of down to bare bones. It's really just about getting that revenue that we need to cover. So
Well, I mean, if you look at it from a budget perspective, if you look at it first half of the year and second half of the year, so you at least can share with us. Maybe you're not gonna get there in the first half of the year, but maybe things are gonna change in the second half of the year. We're not trying to tell you, you know, we gotta do it tomorrow, you know what I mean? But maybe you have to have some basis of how you're developing your budget. right?
yeah,
So you can't just say, I'm gonna go based on last year's experience, right? So you gotta have some databases on how you're gonna get to your budget, including revenue. You know, costs are probably well known by now, you know? So really, it's how do you get to the revenue line that you're gonna commit to?
It's hard for us to look at you coming in with the same expenditure budget without revenues going up. You know, and since we're looking for less of a deficit, if the only way to get the deficit down, if you're not gonna generate more revenue, it's gotta be on the cost side. You know, I see here in your goals, you have create a 1, 3, and 5-year goal to continually decrease losses. We'll anxiously look for that plan when your budget comes to us this year. And I hope it'll be in enough details, not just to say I want to only lose 800 this year, 700 next year, 600 the year after. I think to give it a good effort, you've got to have what the expenditure side in detail is going to be versus the revenue.
mhm,
So not just come in with a goal of cutting it by 100,000 without being able to say how you got to that, showing us whether you're looking for increased revenues or decreased expenditures.
mhm.
And for me, looking in, it seems like he's doing the right approach by looking at the numbers specifically, even though as you say, it's gonna be hard work. But it falls you to do it. Sorry.
It's gonna be done, you know, there's work to be
Yeah,
done.
It's gotta be done. I think that you have the right attitude. I only hope this will It's not do before, and it didn't. But that's where it comes from. It's in the details. Yeah.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you for having us.
It was a pleasure meeting you guys.
Yeah.
Yeah. I hope we didn't overwhelm.
No,
you.
I think it was good because,
The information, but maybe we can meet again, or if you have questions, and I can get back to you in the email and share kind of the month over month.
Or digest the
Finding-
handout and then come back with
Yeah.
questions, or you want more information, and you can.
But I'm definitely not a finance person, so I'm looking to this table, to help me. And I understand how we operate, but maybe you have ideas that I didn't think of. Or maybe you can help to formulate the plan, or maybe somebody has a good template or a resource, I'm looking to learn and grow in this area to make it work.
but what position were you hired for originally?
The administrator,
Oh, back at last February,
no, March, the end of March.
last month. Okay.
You guys have a full board right now?
No.
We have one
Well-
open.
You have one open,
I think. Someone was supposed to.
an accountant.
We don't have a very
Robust.
participating board at the moment.
Mhm.
It's very hard.
I recognize that the moment I joined. There was, I think, there
I
was
don't-
6 openings when I took the call from Facebook and said, the VNA has 6 board openings, and I had just left my job. And I was like, oh, it's a calling. Little did I know what the calling was, to be on a volunteer board and still have a full-time job and come into this. So, but I'm happy to help, but there's a limited board, just to be very transparent. Knowledge and understanding of home care is very unique. And if you don't have that, it's very hard to really understand the lingo and the language when we're talking about all of these metrics. And that's where Aaliyah, I feel like we're supporting each other through this. In my experience previously, trying to come up with financial board reports, that would be what I think you would be helpful, but also the systems here are not as sophisticated as
Yeah.
where I came from. So there is that manual work, which it's a huge lift, but
How
we're
many-
getting there.
How many open seats then?
There's one right now.
Oh, just one.
I think we have 3 coming up that are, will be, 2023, January 31st, like terms. So it is an opportunity to reevaluate the engagement of the board, because we really need, people to ask questions and engage. It just shouldn't be the Aaliyah Kara
Yeah.
kind of show, because that's not beneficial either. You need people to question, just like you did here. I mean, that's a good kind of health check to have those questions as well, so.
And I think my biggest issue with coming up with those plans and the budget is that you really don't know what you're gonna get. You have no idea how many referrals, you have no idea what that insurance is gonna be attached to them. Sometimes you get on a patient and then something else happens and then they're more costly than you anticipated, or the doctor changes.
We do budgets every year,
So
so we
it's just,
understand.
yeah, but I think there's other departments in town that definitely have like your just anticipated fixed costs, whereas our department, there's almost nothing fixed when it comes to reimbursement. You just don't know.
Inflation kind of throws monkey wrenches into
Yeah.
those static budgets too.
So I could imagine, but I just feel like there's a lot more working parts. So coming into a real firm,
It's your first budget,
Yeah.
so it'll be
yeah,
looking at history and doing averages.
yeah,
A lot of averages, looking at what year and then coming up with a
Well,
model.
that in part of what you need to do is what you're doing when you're looking at per diem help and whatever, that's the float in
Yeah.
your budget to some degree,
Yep.
right?
for sure.
Because that's not necessarily money you have to expend if the business doesn't show up, and if the business
Oh,
doesn't show up,
yeah,
then you
exactly.
can increase that.
Yep.
That's.
So the majority of our staff is on per diem, the aides are not, occasionally the aides have been short, and we are actually short an aide on the school side, so we've been sending them there to kind of backfill that side anytime they've had time, or they come in and do other projects that I give them related to the agency, so.
So when they go to the other side, do they charge them?
The charge
I have to ask payroll what,
to Department 61.
Who, if they're working for the Board of Education, are they charging? them
Well, they're not
for
for-
education?
well.
No, I mean,
yeah,
if you
let's
send
step
somebody
up.
over for a week or whatever,
Yeah.
Is it coming?
they should be charging them, not.
What they do is they report their hours on a daily basis, either to the BNA department or to the Board of Ed department. Charged to the Board of Ed department, it goes through the health aid line, to the Board of Ed. If they charge their time to the BNA, and they could be splitting a day too, it could be.
No, I know.
Yeah, like
That's
today
what I'm
we had
asking.
one that was splitting, yeah.
Now, recently, and it's not your budget, but you oversee them, the school nurses. Is there someone who was hired to oversee all of the school nurses?
So Margaret is the nurse, school nurse coordinator.
Okay.
Yeah, so she manages the
Right.
day to
Is that a
day
recent hire?
of the school side. That happened a year and a half, maybe 2 years.
Probably about a year ago.
A
Okay.
little over a year.
And that's all charged at 60.
She was in
She's- yeah.
61 and that was all 61. And just to clarify, Aaliyah does own the nursing and health aid portion of Department 60. Department 61 is actually owned by multiple people, facilities, grounds,
Every.
nursing.
Yeah.
As
Yeah,
well
St.
as she
Paul.
oversees private schools, which is St. Paul right now, it used to be Moreland Hill as well.
Well, thank you very much.
Thank
you.
you. Please let me know if there's questions, and I'm looking forward to.
Thank you, yes. thank you.
Anything I can learn.
Thank you.
Thank you.
Go to item 2, did everybody get a chance to review the Board of Finance meeting dates?
Valentine's Day, really?
Sit up and everything, you know.
I'm just pointing out to my wife, it's great.
That's the worst day to go to a restaurant.
I got a Board of Finance meeting, I'm getting through it.
So there, we have to vote on it?
You can vote to adopt it.
Remember against that date specifically on the record.
That'll cover you.
Yeah, exactly, exactly.
Right. Make a motion to approve the Board of Finance meeting dates.
Motion to approve the finance for,
Motion done.
yeah, motion to approve.
Second,
Second.
all in favor?
Aye.
So moved. The next one is proposed FY24 budget calendar.
Make a motion to approve the budget calendar as proposed.
Second,
Second.
question? Those in favor?
Aye.
So moved. Okay, Kevin.
I'll be brief with the finance director update. Really, the revenue we've done pretty well, pretty consistent with prior year, in good shape. One thing I will point out, the health insurance area got a little bit tighter, revised IBNR, incurred but not reported from Anthem, as we are just finishing out the audit. The claims patterns are getting more in line with pre-COVID. They had some delays in claim processing, so they've adjusted their triangles, they basically spread it out, and we're back more. So that number went up about $290,000. So that tightened, still solidly, we're at 26% versus a expected floor policy floor of 25%. So there's not a risk there. That's probably the biggest driver of the tightening. And then, you know, the only thing I will say, we spent a lot of time on the VNA. You will see that the revenue, year to date, 23 is largely in line from a revenue standpoint, with 22 and 21 slightly behind 20. So I would continue to say that probably going to land $600,000 in fiscal year revenue. Still have the year. All communication. We're gonna end up. That's it. There's no.
What was the budget bonus? 900?
900.
That's why I don't see any risks and opportunities, 3,000 risk on the DNA revenue side, as well as small risk. Abilities of it. We'll be able to offset with some other items. Staffing, we'll talk a little in executive session about police, but that's the biggest wild card right there is what's going to happen. At least since the beginning of this year, 4 police officers are police force. So that's obviously not good. It's a struggle. They have one person in the academy who has resigned.
2 days in.
We do have another officer and the chief and the leadership team continue to interview and continue to try to recruit.
Kevin, just a quick question.
Very good luck with the recruits. Not at all.
Quick question. Your risks sheet shows BNA receipts 300,000 short. Where would that put this year's loss for them?
Actually, I'm right now, if I look at the P&L and project out the year, our loss at this point versus last year is slightly smaller. On those purposes, I would put it in 750,000, essentially where it was
Even
last
with
year.
this 300,000 short.
I think one of the biggest reasons is because of the per diems and some of the other things with the nurses. Because of that, we're able to bring some of those costs down.
Thank
So
you.
the per diem model is actually working fairly well.
Well, I mean, it's working as intended. Ideally,
The loss is the same.
Yeah.
It's just not really doing anything.
I mean, I just did a quick straight line, and the straight line is different than what you're saying, it's closer to 860,000 loss, because all I did was take the first 5 months and straight line everything.
one of the things you have to be careful of with this year is the nurse's contract was just settled. And so the month of November included a 1.5 retro payments in there. That's gonna happen once, it's one hiccup, and then the rest of the year will be at the new rates with that spike in 1.5 catch up on previous pay, when the contract was negotiated, won't repeat itself.
And we're gonna go into executive section.
So at this point, decide we want to invite in, and
Well, it's all the Board of Finance members and both Kevin.
I don't choose this point of having to leave.
If nobody else is online.
Just Mark. So once we go there, stop recording, obviously.
Okay.
We'll shut down the recording, we'll let you know when we come back out of executive session, you'll just make a motion to, if you want to add anything to the agenda, you just make a motion to adjourn. No, so she can add it.
Do we need a motion to go into this session or do we just
Realistically, yeah.
make a motion to go into executive session? Strategy.
Sorry.
Can you check what the chat?
That was Mark originally. So, yeah, here.
I'll second that.
I
Move. You got it, Kevin?
I will.